Hello, everybody. Thank you very much, Ellen, for the introduction. And before we start off, I just want to say also thank you for all the experts that we have here on the panel. I see in the audience a lot of professionals and some people that I know as caregivers as well. So I'm glad that you're here. And we've done the best that we can to gather some of the key agencies that we often meet with and some that we hear a lot about, but we're going to have some detailed questions for them. Alongside with some of the questions that we have prepared, I want to invite you to also put in the chat box some of your questions. I'll do the best that I can kind of monitoring, but Ellen's going to help me out with in the chat with monitoring the questions in the chat box. But we want to make sure that while we have some of these key agencies here, that you get some of your questions answered, because they probably are very similar to what some of the other people in the audience have want to know about too. So this topic is something that is very central to those of us that work with older adults who are living with dementia. We know that psychological symptoms and behavioral abnormalities, they're common and they can be prominent characteristics of people who are living with dementia. They might include symptoms such as depression, anxiety, psychosis. They may have agitation, aggression, disinhibition. And so we can say that approximately 30 to 90% of persons with dementia suffer from behavioral disorders. And a lot of times we're not prepared for it. We don't know how to deal with it. And for caregivers, it can be a very scary time. And they reach out to the agencies that our panelists work with. So there's a lot of very complex interaction between what's going on with the person and how they're presenting outside. One of the first questions I have is to the Elderly Protective Services Agency. Tamala, thank you so much for your dedication. I've worked with Elderly Protective Services and Adult Protective Services, and I know the strain that the agencies are under, and I know the volume that you have to deal with. Your work with protective services and the workers that come in contact with cases of persons who are not yet diagnosed, but they're starting to behave in a manner that is concerning to either the public or concerning to their caregivers. So we know that your agency comes in contact with this. One of my first questions, Tamala, is can you tell me about what specific training your staff members go through?
Okay, well, initially we conduct a supervisor's training where we provide information on what signs and indicators to look for when our specialists go out to investigate our elderly population. In addition to that, we have in-service trainings from different entities that provides information, pertinent information on how to handle clients with Alzheimer's or dementia, or just how to deal with them hands-on. We also send our staff to conferences that provide information on our Alzheimer's and dementia clients, on how to work with them, signs, what to look for, things of that nature.
Excellent. We know there certainly with the growing volume of persons living longer and the large number of expected of persons who are going to be living with dementia, that we need staff who are going to be interfacing with clients and family members. We need them to be trained. So that is good news. And I know people sometimes will speak to say, oh, yes, we have training, but it really does take identifiable and defined training in this particular population. So I'm glad to hear that.
Thank you.
I have another question. Sometimes, we refer somebody, I say, well, this person's this old, and so I'm going to go ahead and call Elderly Protective Services. And a lot of times the family members are not familiar with what that entails. What does that kick off in terms of, what will happen next? Can you describe to the audience, specifically to caregivers, and of course professionals as well, what steps they can expect when a call is made initially to Elderly Protective Services?
Sure. They can expect to speak with an intake specialist. The intake specialist is going to request information, the reporter's name and contact information, the client's information, name, age, date of birth, social security number, medical information, financial information, what the call is about, names and contact information for everyone who's involved in the case, because we're going to conduct a thorough investigation. So we have to have all of that information. Once the intake screen that information to make sure that the abuse meets the criteria for our agency to investigate, then the case will be assigned to one of the specialists.
So you mentioned criteria. Can you go into a little bit more detail about what would be criteria
Well,
that would be a flag for you?
Nursing homes. Like if you call in about a nursing home, that is not a case that we will investigate. That's a licensed facility, and those type of cases are investigated by health standards. So the cases have to meet the criteria for us to investigate.
Okay, what are some key words that would be helpful to the audience to know that are, that yes, this does mean that I need to contact protective services. I know that, social workers, those of us who are social workers in the audience, we're certainly, we're mandated. We have a mandate, not just social workers and nurses, teachers, but what about a caregiver? What might be something that would be, an identifier to a caregiver that they need to contact?
A caregiver who has power of attorney over a client, and they're responsible for their finances, making sure they get to the doctor, making sure they have the care that they need in the home. They're handling all of those affairs, but those affairs are not being met. The clients are not going to the doctors. The clients are not receiving their medications. They're found in the home wet. They're bedbound, things of that nature. The caregiver is supposed to make sure that that patient is receiving adequate care in the home. So if the caregiver is not providing that, and they are in the responsible party that is responsible for that, that is a case that meets our criteria. That is the case that needs to be reported to Elderly Protective Services.
Because a lot of time, certainly there are persons who are living with dementia that are, they have periods where maybe they are showing aggression, but there's also sometimes when they're not able to take care of themselves.
Exactly.
And one of the things, of course, we know about when people respond behaviorally is for them, it's a matter of communication, and they can't always communicate that. So anybody in the community, caregiver, we would want them to do some further, stepping in and maybe contact protective services. I have a question for Dr. Clark. What we know that in most crisis situations with a person with dementia, the connection that your staff makes with the client out in the community is very important. Could you explain what kind of training your staff goes through regarding older persons or persons who may have dementia?
So I think before I answer the question, let me just make sure everybody on the call kind of understands the role of the coroner. There are 64 coroners in the state of Louisiana. We have 3 jurisdictions. We're probably most known for our jurisdiction in determining the cause and manner of someone's death. In East Baton Rouge Parish, which is the largest parish in the state, we work about 4,500 death investigations a year. There is another jurisdiction that a lot of people don't know that we have. It has to do with the involuntary committal of the mentally ill. And these are people that are suffering from mental health crises that are in need of involuntary admission to a facility for evaluation and or treatment. We do about 10,000 of those cases a year. It's actually our largest jurisdiction out of the 3 jurisdictions that we have. So what does that entail? It entails 2 parts. One is the ability to have someone picked up from where they're at in the community if they're determined to be a danger to themselves, a danger to others, or gravely disabled, and have them delivered safely to a facility in the community for an evaluation. So you can think of it almost as mental health EMS. There's several components to that, and that process is called the order of protective custody. There's several components to that. One has to do with interacting with my administrative staff to handle the administrative matters related to Louisiana statute in this process. The second part to that has to do with the execution, which involves the delivery of the legal documents as well as the individual that we're taking to be evaluated. Louisiana law provides that that duty falls to law enforcement, and typically in most parishes it is done through the duty of the sheriff's office, because on a political spectrum, sheriffs and coroners share the same level. We have different duties, but we're the same political entity. The East Baton Rouge Parish Sheriff's Office supplies us with several deputies that have been specifically trained through crisis intervention training in picking up these individuals, typically in weekdays and during the daylight hours. Now, it's not to say that orders of protective custody can't happen on weekends and at nights, and typically that falls to uniform patrol deputies with the sheriff's office who do have the same training. However, I will say the difference between the guys that do it regularly and the guys that do it on weekends and nights is the guys that do it regularly, that's their job. Every day they're dealing with these individuals in our community. And it could be anything. It could be the patients that we're talking about now, the individuals that are elderly with dementia, but it also could be young schizophrenic patients or people that are suffering from substance abuse or addictive disorders. So their crisis intervention training is held specifically in how to manage and handle those individuals, taking into consideration their safety, the safety of the officer themselves, as well as the safety of the individuals that are around. So that hopefully answers your question.
Very good. Thank you so much. Wow, 10,000. That part of your job is 10,000 calls that you have to respond to.
Yes. So the orders of protective custody amount to about 1,000 a year. And then on the back end of that, when the individual gets to the facility, if they're going to be kept in confinement involuntarily for up to 14 days, we get back involved with something called the coroner's emergency certificate, and we do about 8,500 to 9,000 of those a year. So that's where you get that 10,000 number.
Wow, that is certainly a large part of your responsibility. That's
Yes,
a big part of the pie. Thank you. I will say this. When I've had to deal with the coroner's office, I mean, I'm talking decades ago when I had to go down to the coroner's office and actually sign paperwork. And then when I was on the other end, when I was someplace and I interfaced with the sheriff's deputies who were picking up persons, I was very impressed with they were very gentle and very kind. And so when I had to, refer somebody to that process, I would often tell the family members who are afraid, not knowing what the next, what that would be, a law enforcement coming to their house. I would tell them that in my experience, it was a very dignified and courteous, as much as possible, interaction between the sheriff deputies and the person needing help. And that's something that stuck with me all the time. And I'm sure that a lot of that is related to the leadership philosophy in your office. And thank you very much for that.
Thank you.
So you did talk about the order of protective custody. If somebody needs this done, of course, with COVID, I mean, things are going up and down with COVID, and right now things are looking better. But right now, does somebody still have to go to the office? What does the process look like right now?
So the order of protective custody is actually an affidavit. It has to be signed and witnessed in person. So it cannot be done over the phone, through email, or anything like that. You actually have to come and sign the paperwork. And the purpose for that is actually to protect the safety and rights of the individual that we're picking up. Because you can imagine there are certain times when someone might file a false order of protective custody to get back at someone. Probably the most common scenario we see that in is when two individuals are fighting through a divorce and they're trying to OPC each other illegally. And so that's why that affidavit is in person. And it's also important to understand that the affidavit is a public record and everyone has a right to access it, including the individual that's being picked up. And that's to keep us all honest, because this is a very important safety net for our community to make sure individuals are protected, either from themselves or from other members of the community. But we also want to make sure when we're going to take someone's rights away by picking them up and having them delivered to a facility, which is, somewhat counterintuitive to our own personal civil rights based in our U.S. Constitution and state constitution, that we do so in a manner that is fair for all parties. And so that's why that order of protective custody has to be done in person and can't just be over the phone. The other important keys to it is that the individual who's making the affidavit does have to be a credible witness. You can't say things like, well, I heard from my neighbor that, 2 weeks ago, the guy down the street did this. That's not a credible witness. You actually have to have witnessed the behavior. And it has to be recent witnessing of the behavior. You can't say, well, 6 months ago, someone told me they were going to hurt themselves. That's not recent behavior. It has to be within the last, 24 to 48 hours. That's the purpose of the order of protective custody, is the safety net for our community.
Wow. So a couple of things I did not know. I didn't know that that was public record. Actually, I thought that that was still, confidential and kind of like a HIPAA document.
Well, it's not a HIPAA document because remember, there's really no patient involved. Even though we're talking about an individual, we are not examining that individual. The person who's we're filing the order of protective custody are is not present in my office. The office is simply taking the word of the affiant, based on its merits. And so that would be no different than if you filled out an affidavit that you were a witness to a bank robbery. You obviously would have to do that in person with law enforcement, and realize that if you accuse somebody of robbing a bank, you could be held liable, civilly and even or criminally if you were making a false statement.
Well, yeah, now I'm just out of my curiosity. If somebody wanted to see a copy of that order of protective custody, how would they do
So
that?
you would come to my office and you would present identification. We have to confirm the fact that you're over the age of 18 to release that document. And then you would have to give us specifics what the document is. So you can't come down here and say, I want to see every OPC for the last year. That's not how that works. You want to see something specific, then we can certainly release that document.
Okay, very interesting. That was very new to me. That's good to know. And you did bring up that generally there are office hours, but there are times that it might be necessary for off hours. Would somebody would they call your office and you have somebody on call, or would the person needing somebody to be picked up, would they have to call law enforcement?
So I would always say, you got to think of it in terms of crisis and emergency. What do we do when we have an emergency, regardless of if it's a fire or a healthcare emergency? We'll dial 911. And so that's where it all starts. Dial 911 and let them triage the call. If it's an immediate emergency, we don't want to waste time on, coming to my office and filling out a document. Believe it or not, law enforcement actually has the capability to put people in protective custody outside of filing the order of protective custody through a coroner or a judge. So it affords them the opportunity, if they witness the behavior, then they become their own affiant in the situation. So if it's an emergent situation, then getting the proper authorities to the scene immediately is most important, and that's done through 911. However, in other circumstances, when there is time allows for it, then you would come to the office and file the order of protective custody. So, for example, if something was happening Sunday evening that wasn't emergent in need of 911 immediately, then you would just come to my office Monday morning and we would take care of business as I described already.
So we had, I had asked about, what kind of training your staff has, and I see in the chat that Barbara, the executive director of Alzheimer's Services of Capital Area, is reminding us that Alzheimer's takes a big part in training police, fire, and EMT responders. So they, first thing, of course, is teaching them how to recognize dementia and communication and behavioral challenges. And fortunately, we are seeing more and more education about how to talk to, communicate, and approach persons who may be in a crisis and then, because of dementia. And actually, Dr. Spurlock and I, we work together on also another effort with a geriatric workforce enhancement program, which is a grant that we train professionals as well. So I'm glad to see a lot more of that. And obviously, a lot of this because more and more persons are getting older, and we are expecting a larger volume of persons living with dementia.
Yes.
I'll tell you what, I'd like to ask the next question of, kind of what happens next, and we're going to bounce around a little bit, but I would like to talk to Shannon. Shannon, you work in a hospital. Of course, you're probably seeing a lot more of this in your hospital. Alzheimer's is the 6th leading cause of death. We are expecting 15 million people. We're expecting things to triple before 2050. When I was looking up the numbers, actually, I was seeing that Louisiana was in the top 5 highest numbers of persons with Alzheimer's. I wanted to ask Shannon Ragusa, tell me about what training your staff goes through. So when they go to the hospital, what level of training can we expect that your staff members will have regarding this specific type of client? You might be.
Sorry, I'm muted. I was
Okay.
muted. One of the main trainings that we do, anyone who works on any of the floors that we have specifically on, we have one particular floor that is for patients and clients that have dementia, is it's called MOAB. And so what it is a training to de-escalate both physical and verbal escalations. It's a day-long training, and part of that training, one is a classroom portion of it is for 4 hours. But then the second part of it is that we work together and act out different scenarios and are required to practice and pass with those efforts and practice those techniques. Another thing that our facility has is that we do trainings throughout the year. So we're able to do regular trainings in services type things. We also do on the spot coaching. So we're able to monitor and provide support and assistance to any of the employees that may be struggling. We do move them. We have 3 different units. So we're able to kind of monitor that there is, you can get burnout sometimes with that population can be challenging for them as well. So when we have an open line of communication where they're able to come and tell us, hey, I need to move to a different unit for a little while, and we work with them to do that. In addition to that, we have cameras throughout all of our facilities. So we're able to monitor the interactions with the patients that are there. Specifically, we do it sporadically. We have several managers that are also on our team. And so all of us are able to pull up the cameras, watch the interactions from our desk, from anywhere, from home. And we can see what's happening on the units and provide the coaching, because there are times when we need to add in additional coaching, but they get a yearly training in addition to regular in-services on the spot coaching. And we talk openly about the stresses that occur on those units. So it's not something to keep quiet about. If we really care about how the employees are feeling and being able to communicate with us when they have additional needs, and we can support them in that way.
Right. We often say that, the weakest link is, the person that is working directly, but, and we want them to feel good about themselves, about the work that they're doing. We want them to have support, because these clients can be very challenging. And if they're not educated about how to deal with that, burnout often comes because people don't have enough education about their job and then feel unprepared. I'm very impressed. I'm glad to hear that. Thank you. One of the things we do know too, that sometimes a person, sometimes this could have been prevented. And even with a caregiver or a family member or a friend, this could have been prevented earlier on. In your experience and work in your hospital, can you share what are some common experiences that you've seen that you'd like our audience to know about and to be prepared for in terms of when a person reaches this level, you know, what would you like the audience to know about, and maybe what you see could have been prevented?
Well, I think one of the things is when we're interacting with families, oftentimes there is the opportunity to provide some education related to what does the disease process look like, and what things, sometimes when they're having escalations, there can be medical issues that are causing those escalations. So ruling out some of those medical issues, we are able to do that in the hospital a lot of times. Sometimes people do come to us possibly through an emergency room or different means. So we're able to rule that out pretty quickly or rule it in and be able to treat that. But I think just understanding the disease process and recognizing too that sometimes for instance, I think there was a question that was sent to me about sexually inappropriate behaviors. Well, sometimes we can see where people may have a UTI or some type of medical issue like that, and they may be, they can't verbally communicate sometimes what their needs are. So we notice that we may see some behaviors that happen related to that, maybe touching themselves, and that seems inappropriate, but in some ways we can be more attuned to kind of what's happening with that individual and and definitely it takes a team. You have to have a team that you work together with, so a physician and other caregivers that work with you. But I think the biggest thing is that I run into really with families is being knowledgeable about what the process is. I am also a caregiver. I assist my cousin in caring for my aunt. And one of the things that for our family is one of the most important things is we see agitation a lot of times when people, I'm going to give an example. This came to my mind. My aunt called me not too long ago and she said, I've got to tell you something that's really terrible that happened and you need to know about it. I said, okay, well, tell me what happened. She said, your father-in-law saw me at a Trump rally and he and his friend hit on me. And I really don't think this is right. And I need you to do something about it. And rather than say to her, no, you didn't go to a Trump rally and he didn't go to a Trump rally and he's not hitting. I said, wow, that must have been a disturbing experience. And rather than her escalating, because I'm trying to tell her what she had a dream, I think, of some sort, and she remembered that. Instead of arguing with her about what's true, I often tell families too, would you rather be right or be happy? And part of that is sometimes it's okay not to correct them. My aunt calls and tells my children all the time she's going to send them a check for $2,000. Well, part of that, my job is to help my children understand that their aunt doesn't understand the value of, or she can't understand money. So she's sending you $20. And when she says that, just tell her how grateful you are. And that's what they do. So part of it as a family is educating. I work in this business, and when it hit our family, I can tell you that there was still a learning curve, because when it hits you, it's different than being a clinician working on those units. So I think the more knowledgeable we can become, also just paying attention to a lot, can be agitation too, as probably many of you know, in the evenings, but also with with sound and light, and to have a calm environment. And really, like, they may have been somebody in the past that enjoyed watching TV and enjoyed watching it loud, but as the disease progresses, they may not even be able to follow a television show. So that might not be something that comforts them anymore. So just paying attention to some of those things, I think, and not arguing. A lot of times on some of the families that we work with, they want to make it right, like explain, no, that's not right what they're saying. But sometimes it's okay just to let it go and not escalate the situation, really.
So we do know that family members are, a lot of times they've gone without sleep. This is new to them. Maybe their family, their loved one or their friend or their neighbor is escalating, and it's scary to them, the vocalizations or the paranoid delusions. And that can be frightening to somebody that is not ever seen it. And like I used to tell staff is that, we see this every day, but to this family, this is the worst time of their life right now, dealing with their loved one who is decompensating this way. And they need reassurance. but they need education. And so I'm hearing you say that you do talk to families about it. Is there a formalized education, or, is there books you recommend or handouts? What do you do to help the family in that way?
Well, quite honest, we have them for such a short time. A lot of the education that we provide is with the family. Our physician is great about contacting he gets involved in communicating with the families, which I've been very appreciative of. But so we don't have a formalized training that's there. We do link them with other services. Sometimes it is with the Alzheimer's Association. It's a great resource. We do have some pamphlets and different things that we share with them, but primarily we offer them the opportunity to meet with a social worker. Sometimes we do families. It depends. Recently, we had a family that was deciding. One of the biggest struggles that we run into is deciding if a different housing option is needed. And so there's sometimes we go through the different housing options that are available, what resources they have, what options that presents for them. And so just walking them through what the options are, because it can be scary. And there are at times, self-care is so important. We always talk to the families about being sure, especially if they're with us for that time, we encourage them, take some time for yourself. They're going to be here with us. We're going to take care of them. But it is very challenging. Even if you do this every day, if it's your family and you're providing caregiving, it's a whole different ballgame, because it's not recognizing that sometimes the disease is talking to you rather than that person that you knew at one time. Because there are things that they'll say or do that person prior to having dementia would have never dreamt of saying or doing.
Yeah.
And so it's, and then there's resources anyway. I mean, we can get resources at a tip of fingertips. You can look on the internet and find the topic and the resource that answers the question that you're struggling with. And I mean, I don't mean to diagnose somebody, but I mean, there's even self-care support groups for caregivers. There's resources readily available. And so we talk to them about how do you access those resources. And so just walking them through what's easy for us isn't necessarily easy. Sometimes for the family member, they may not know those things are available. So we educate them on that while they're with us and give them the best chance for a good outcome when they discharge.
Right, that's a good point, because people do often think still that when they have their family member, their friends goes to the hospital, they don't really recognize that this really is just a place to stabilize them.
Right.
And their treatment will continue someplace else. And a lot of family members are unhappy about that because they recognize that there will still be some problems. Possibly some problem behaviors. But you also bring up, of course, like one of the number one things that we look at first, UTI, right? That's what I always, especially when there's been a behavioral change that's sudden or unexpected, or they become aggressive, we ask the family members that to make sure this gets checked out. So let me, in this today, we have several scenarios that we've chosen to that we want the panelists to respond to. And so we have a scenario. Shannon, if you let me walk this scenario to me, and you tell me what you would do in this situation, or what you would see best. And it's similar to what you've been saying, but so somebody says to you, my dad, they've come in, and my dad has been agitated, angry, and striking out. But when
that's not it.
Okay. But when he is in front of others, he doesn't do this. And this happens at hospitals, right? They're saying like, oh, he's being fine with you all, but when he's at home, he's completely different. Doesn't that happen a lot? And they say, I'm afraid to be alone with my dad because he might explode. Then I'm going to be there at home alone. And you will have discharge. I don't know what to do. So what do you recommend steps that I take?
Well, I think I said this earlier. One of the things is to have a team that works with you. So one would be a physician, and I guess there's different that y'all had sent me that, and I've spent some good time kind of thinking about it. There's all different levels. If it is to an emergent degree, then if you feel that physical harm that they are going to harm you, then there is a time, of course, that hospitalization may be something that's needed. And it can be accessed many different ways, but after hours on the weekends, we often do have people that come to our emergency rooms that they're able to access resources there so there's different levels. If it's to that level where there's a risk of imminent harm and you're concerned about that, then reaching out to for a higher level of care is something to consider. But also, and working with physicians to see different, I mean, every case that we see is different. So we see some, when you say with medications, there's some medications that we are able to work with, but sometimes also just really communicating with the physicians. And sometimes it's too much medicine that is contributing to a problem that we see. So it's really working with, if it's a neurologist, a psychiatrist, psychologist, gerontologist, whoever it is that's going to be a partner for you in this journey has to be involved in these situations. So if it escalates, we all the time, every day that we get an admission, it almost always is they're not necessarily doing that behavior that they're saying. So what we try to do is really work with the family to find, are there any triggers that are contributing? For instance, maybe it is about providing a more calming environment, or maybe it is knowing how to respond when they're asking different questions, having somebody that joins you in a diversion. I mean, and looking into options. We cared for my aunt at home, and it was a very difficult time when we came to realize that we weren't able to continue to do that at the level that she deserved. So as a family, we had to sit down and talk about what's going to be the best next step for her. And sometimes it is looking at different options that it can get more than what caregivers at home. So, I mean, I know that's not always a popular thing to discuss, but just exploring all the options to provide the very best care and to be able to stay healthy, to be there for that person.
Yeah.
So I guess the thing that in close is if they're striking it, you have to be able to communicate with that, ask for help, try to figure out exactly what are some of the things that contribute to that, if at all possible. And then if it is in an emergent situation, to reach out for the resources that can help.
Yeah, and you were saying the team approach is really a lot of caregivers that I talk to are some of them have family members maybe, or other caregivers that have separated themselves because it's something that they didn't want to participate in. So sometimes it's just one person doing this now, right? And I tell them this is going to take a team. And I know you might feel okay right now. Maybe right now you're feeling healthy, you have energy, but as this progresses, you need a team, and a lot of times they have trouble asking for a team, and that's another whole topic. Yeah. Explain how that's going to be part of their loved ones' care, is that it can't be all on one person.
I think that's part of our role too, is to, when they're there, is to look at all the resources that are available to them and to the family, and to work to help them in building a team that we can advocate for them. And oftentimes we do that, to find the resources in the community or come up, we don't always have the magic answer, not always, but we really try to come up with a way that they can have the best outcome.
Good. I'd like to ask Dr. Spurlock. Boy, Dr. Spurlock, I'll tell you, she has been one of the first people in this community that really worked with this cohort of older adults and made it a specialty, and worked with the specialty. And I've known her for I don't know, Wanda, over 30 years. When it was a small specialty. And of course, now we depend on the work that you do, Dr. Spurlock, and training people, nurses at Southern University. That is so important. I do have a couple questions for you, because one of the things that I want to ask you, and I know that you've talked to this in other presentations, but what could you share? What are some techniques or steps that you would recommend when a family member starts to see a situation escalating?
Mm-hmm. Yeah, so that's a very important question, because throughout my career, that has, often been presented. And so I think, first of all, we have to put the behavior into a context, so to speak, because just saying what the behavior is without a contextual basis for it, then it's really, a lot more difficult to evaluate, per se. And then also, and we've talked about, different behavioral strategies and all, but I also emphasize to family members in terms of, person-centered. So that's another, like topic per se that we can, merge into this. And oftentimes, family members, and I found throughout like the 4 decades of my work as a nurse, with persons with, cognitive impairments, mainly dementia, is that we want to tend to focus at first on stopping the behavior. How can I stop this? How can I stop the behavior? And so I would say really to put more emphasis on trying to understand the behavior. Because of course, persons with dementia, with, impaired, brain, functioning and losing the ability to be able to articulate, to communicate, is that we have to understand, first of all, that the behavior is a form of communication, for them. And so then we need to, really put on our, Columbo hats. And I would often ask my students, which of course they aren't usually old enough to remember, the private eye Columbo.
Who knows Columbo anymore?
He would walk around in that trench coat stained with coffee and appear, disheveled and all. But look, he was definitely doing his assessment, step by step, uncovering, just peeling back, various layers and all. And at the end, he would always be able to solve that case, to solve that, mystery. And somewhat, similar to that, that's the position that, family caregivers and persons, healthcare providers, also enter into that arena, more or less to try to understand the behavior. Because, oftentimes it may not seemingly have meaning to us on the surface, but if we look at the person, in the context of their entire, life experiences per se, in terms of their, environment, then oftentimes we can start to, piece together in terms of, first of all, what may be precipitating, the behavior, to look for some antecedents, so to speak. So we can't just say, okay, this is a behavior. We need to try to prove it. I mean, we need to try to, stop it. I need to get some medications for it. But again, just try to understand. So what seems to be the antecedent in terms of triggering, as was mentioned before, what's triggering the behavior? Is it something that's, environmental, as was mentioned, something that's happening, could be noises, lights, sounds that the person is not really able to channel all those different layers of stimuli. And so oftentimes we see that will evoke what I refer to as a catastrophic reaction, when the demands more or less exceed that person's, capabilities to be able to, handle and manage the stimuli and then to respond to it, appropriately. So I think, first of all, it goes back to trying to understand, the behavior, the precipitating, cause of it, looking at it within a contextual, situation, because even when you seek assistance of a healthcare provider, they're going to need some more detail. They're going to ask the same types of questions. But what seems to be happening, perhaps at the time that this behavior, is occurring. So we're looking for patterns, we're looking for trends, and then we can try to track, the behaviors once we gather, that initial data, and then put it into the context of the individual. Their life preferences, likes, dislikes, all a person-centered approach. And then also to recognize, because in all of my years and work with, persons and family members and, even my own, is that we have to understand that sometimes, we can play a role in that. So we have to be able to examine our own behaviors, our own reactions, so to speak, to what the person may be exhibiting. And I found over the years that even persons who are confused and disoriented, well, guess what? We are observing them. They're also observing us, in essence, in terms of they see how we are reacting. Then oftentimes they will mimic or mirror what they see us display. So that if we get loud, then they might also tend to get loud. They're going to really mirror more or less what they see, from others. And just to understand, in essence, is that at the end of the day, we're all human. So we have to be able to examine our own responses to see if that might be a factor, more or less, in what may be triggering, some of the behaviors that we see. It could be definitely environmental. It could be, physiological. The person could be in pain. It could be, adverse reactions from medications and all. But then it also could be caregiver induced, so to speak. And that's not only family members, but, professional, caregivers as well. So, and we have to know that this is a, rather complex, process. If we had like one roadmap that we could use with all persons, well, that would just be great. But, although we have evidence-based, strategies and approaches that we can utilize, we just have to know that all individuals are different. So we need to be able to understand, in essence, what may be triggering their behaviors and things that we might be able to modify. Because I've also learned is that, we can't really shape and mold or force a person who has a cognitive impairment, especially one that's, progressing, to be able to modify. They need to modify themselves to be able to meet, the needs, but we have to modify the environment. We have to make the necessary changes, so to speak, to be able to meet them where they are. And that could change on any given day. That can change as they, matriculate throughout the trajectory of the disease process, especially when those behaviors tend to heighten.
Yeah, and I mean, everything you said is right on target. The first thing we do is we want to stop it, but it doesn't start there. It starts way back here, right?
Right.
Knowing the person, understanding them, and recognizing too that as this is going on, our responses to everything they're doing could be contributing to what is maybe not, it could be contributing to a catastrophic, what did you say, catastrophic
Catastrophic reaction.
reaction.
Hmm. Right. I've seen that occur quite a bit.
And another good point you bring up is that when that happens, it's important to stop. And I mean, I know that people do this in hospitals, and let's do a debrief. Let's talk about, let's see what was it, and let's study that so that we can prevent that from happening next time. That's hard for somebody at home alone that doesn't have a team of doctors, aides, social workers, nurses to help them do that. But if they, certainly if it's in a facility, we want to remind the facility that that needs to happen, a debrief, and see that each person might have a little bit more information to share about what they've learned about the person. And document it so that the next shift knows this information, so it doesn't trigger another catastrophic reaction. We're getting some, I'm just going to run to the chat here real quick. And I said UTI, we're so used to using this jargon and acronyms, and Ron, thank you for reminding me that, UTI is a urinary tract infection. And this is one of the first things that people often look to when there's been a sudden change. So when we say UTI, it's a urinary tract infection. And Anne was saying, yes, building a team is so important. This is too difficult to do alone. When somebody's either at home alone, or if you're working in a facility, you have to count on your team members, each doing a part of this. Richelin says, that's why I love life stories. Understanding leads to managing, and then a possibility to eliminate. It's true. If we spend the time in part of the day, in a program, getting everybody's life stories, we know that person better. If we know what they did, what was their career like, if we know that maybe they had, that they wanted to, that being home was very important, and we would know why they were agitated, walking and pacing, and maybe yelling and screaming and trying to get out the doors. Maybe they have a job to do in their life story. So thank you very much, Dr. Spurlock. I'm going to come back to you for some other questions here in a minute. I wanted to talk to Rose. Rose, you work in another hospital with a behavioral health unit. If I can ask you, tell me a little bit about what training your staff go through, because you're obviously probably seeing more and more persons, in this age group. and you might be coming across this issue as well.
Hey, Gina, Rose had to step away for a second.
Okay.
I'll let you know when she's back in. I'm so sorry.
Okay, so let me move back on to, I'm going to go back to Dr. Spurlock. And I know this is a very, this is kind of a hard question, but we know that there's so much going on with the brain. And, this is probably more relatable in a whole presentation to itself. But is there anything, Dr. Spurlock, that you could explain about what's going on in the brain? Just at least make it a little bit more clear. We just hear that it's like a brain injury. There's changes in the brain. Could you speak to that to help some of the persons in the audience and me understand it more too?
And Gina, oftentimes when family members will start to burn out, maybe not understand the behaviors, and they'll start to complain, start to take things personally sometimes, because in their perception, they perceive as though sometimes a person should be able to control some of these behaviors. And so usually when we show them that picture of a brain of a person who has been like diagnosed a brain autopsy per se, and so then they can see sometimes it really brings it home to them when they look at that picture of a brain with a person with
Yes.
Alzheimer's, to then contrast that with the picture of a brain with a person.
The visual
Yes,
is very
visual, right. But then when we talk about some of the changes that occur within the brain, we know that Alzheimer's, it's a degenerative, type of, process per se. And we know in terms of, especially we hear talk about the, amyloid plaques that build up within the brain and the tangles. Well, these are, really structural changes that occur and damage to nerve cells. So those amyloid plaques, form like outside of the neurons and all, and then the tangles inside the neuron. And so what happens, over a period of time is that the brain's ability of the nerves and the synapses to be able to connect and to transfer, information across the brain, all of that process becomes, deteriorated per se. And so then once those nerve cells die off, then they don't, regenerate. So in addition to all of the, the amyloid, the plaques and the tangles, forming within the brain, then oftentimes they can release, like toxins per se, inflammation can set up, and also in terms of a decreased, ability of the brain to, metabolize, glucose, which is of course, needed for energy and all. And then also we know that the shrinkage, the atrophy, that occurs, within the brain. So all of these things are happening, I guess you could say, but behind the scenes, because these aren't things that we can see, of course, with our naked eye when we look at an individual, that has Alzheimer's disease, and especially, one that has, progressed, possibly into the moderate, stages of the disease. And then the damage to the brain has become, more severe. And then we tend to see a lot of the behaviors, so to speak, that tend to, amplify. And then based on, the type of, dementia that we see, the various types can have different, presentations.
right.
So then if we look at the, dementia, with the Lewy bodies, then we know the cortex in that area, of the brain that tends to, suffer the greatest damage per se. Then we'll see different types of, symptomatology. So it may be with vivid, like types of hallucinations that may occur. And then severe, sleep-wake, pattern, disturbances per se. And then with the temporal frontal, lobe dementia. So then that's going to be different areas of the brain, more or less, that would be more severely impacted. And so then, we may see more behavioral variants and, types of, anomalies. So in addition to sometimes various types of dementia, maybe having different forms of presenting, behaviors, to be able to understand that, but then to be able to understand, some of those changes that are occurring, within the brain because it's a neurodegenerative, disorder. And so that is going to result in many of the behaviors that we see. And not only that, but of course, the individual's ability to, communicate.
Right.
And so, when we lose the ability to be able to, communicate and not to be able to really then to make sense of the environment around us, then that's going to also, precipitate behaviors per se.
Tell me, Dr. Spurlock, what your thoughts are about some of the medications that, and I know it's probably a personal question now about, because there's been some controversy about the new medication. I can't even pronounce it. Aduhelm. I don't remember.
So why it's like they go to whatever extremes to find these most difficult names.
Yes, right. Why don't they make the medicine names
It's
easier
like-
for us? But tell me, if what you've seen that seems to be used more regularly with persons who are having, maybe some aggressive behaviors. Do you see, what type of medications do you see that physicians are prescribing?
And I would just say in terms of my, role as a nurse, per se, because, of course, I don't prescribe the medications, but we always want to first rely on non-pharmacological or non-drug interventions
Right.
as really the frontline approach. Because in, recognition is that many of the medications, more or less, that might be prescribed to treat the various, behavior abnormalities per se, can also have their own bag of potential side effects, risk, resultant risks with taking, medications and prescribing them for older adults, with the dementia. And so that's why we always say is that the medications will be, the last line of defense, a last resort per se, in recognition of some of the risk and side effects that can occur. So now I think we had mentioned earlier about maybe the scenario where a person with Alzheimer's and other dementia may become, severely agitated, to the point that that person would be a danger or risk to others. And maybe that's because they're also psychotic, psychosis. And so they may have some of the psychotic symptoms, hallucinations, delusions. Not that we want to just medicate all persons who have delusions and hallucinations, especially if they aren't harmful. But if they get to the point that it becomes an immediate risk, a danger, an emergency situation, then, antipsychotic medications might be prescribed, for a period of time to treat that. But then the principle is always to start low and then go slow, because we know that older adults, just to the normal physiological changes that occur in aging, is that they're a lot more susceptible to adverse side effects for medications. And normally it's the case that older adults also tend to have more chronic, conditions that also require treatment with various medications and all. And so, for some persons on the call that also work in acute care, settings and all, I mean, it's not unusual that older adults may come in with 5, 6, 7, 8, more medications, and they may all be prescribed for various reasons, but that increased, you could say, for polypharmacy, and that can happen also with older adults in the community, because they may be taking various forms of over-the-counter, medications, and not really, realizing in terms of the interactions that could have. And so what I'm saying is that, all individuals are different, and those medications are going to really be prescribed based on the side effect profile, because it's not to say that one medication may be more superior, than another medication, but I found in essence that the side effects, the risk profile, and then base that in terms of the person's, their overall, in terms of, health status, medical problems, illnesses per se, to make decisions, that are based on that. But I think the situation is that we don't necessarily look at these medications as always having to be a long-term to get on the medications and stay on the medications, but they may definitely need, medications for a period of time. And then also to employ the non-pharmacological interventions along with the medication. So, we don't want to ever just rely, 100% on, medications, because the individual still is going to be interacting with the environment, on a day-to-day basis and ongoing. So we have to really to put those, two approaches together. And I always tell family members more or less to be aware, cognizant of the various side effects, that can occur with medications. And so the, physicians, they won't be able to be in their homes on a 24-hour basis. So they're going to rely on them more or less to be able to do some, monitoring for those side effects, and then to be able to reach out, to the prescribing practitioner, and to be able to convey, their concerns, or in terms of if the, individual seems to be maybe doing better or worsening, and to have those timely, conversations.
So so start low, go slow is one of the.
At the lowest dosage, generally, that's how
Yes.
practitioners prescribe with older adults.
And you speak.
Tina, I'd like to add to that, if that's
Sure.
all right.
Sure.
Hi, my name is Jennifer. Dr. Spurlock, thank you. I think that also when you're dealing with polypharmacy and you're a caregiver, it's really critical to make sure that that older adult is well hydrated. We certainly know that in nursing homes, the number one undiagnosed medical problem is dehydration. Dehydration severely complicates polypharmacy issues as well. And when you're dealing with older adults who may have issues with falls, when someone is dehydrated and they're taking medications, if the medications have a side effect profile, which may cause some drowsiness, then the risk of falls goes up. So if you're at home or if you're working in a congregate care facility, you want to make sure to help keep those older folks hydrated. That is a chronic condition that affects older folks regularly and makes it a lot more difficult for the caregiving community. Also, I wanted to add to Dr. Spurlock's comment about treating the person and the environment. Having worked in the geropsych world for a long time, I certainly found that what happens oftentimes is that people think that if that older person is quiet and not very active, that maybe that's all they need is a lot of sitting. But I found that if I did things to create activities throughout the day to help that person feel needed, feel responsible for something, that made a huge difference in the quality of that person's day. So even creating activities like folding clothes, if there are memory problems, they can fold that same set of towels 10 times during the day and not remember it and be very happy with doing that. So those kinds of things can be helpful also. There are cards that you can order online on Amazon that offer reminiscence activities or remembering things. And so you can order those that are age appropriate for somebody. And those are really helpful too for conversation starters. And I think that having things like that to do during the day makes a big difference too. Just like when we're caretaking for younger folks, we keep them engaged and we keep them busy and they're happier. And that's the same for older adults too.
Exactly. Thank you, Jennifer. That's, excellent points. We are very fortunate now that there is so much more attention being placed on, persons living with dementia, because Shannon, you were saying, Shannon, that, you could just really go to Google and there is so much more. There's much more about being able to keep them engaged. And Dr. Spurlock, what you said really speaks to the importance, the return on investment and spending that time and knowing that person really well pays off a lot. Because if you decrease that, if you don't give that the amount of investment and time that it really needs, and you start thinking about what kind of medicine can this person have, you don't recognize that there's a whole, that sets off a whole nother level of issues or
A
problems. that-
cascade of negative events, right?
Exactly, because this person might be on, most probably is on other medicines as well. So now you're having to consider the interactions between the medicines, the, the polypharmacy issue. And does that person gonna stay on this and adjusting it when maybe just early on, a little bit more investment of time, knowing that person, developing, and I'm not saying this is easy. I know I'm just saying it, but it really is worth, being creative with a different plan for the person. Of course, not sacrificing if somebody's in danger. That goes without saying. But up until that point, what are some ways that you can help them with their behavior issues that does not immediately go to a pharmaceutical answer? So just, and that's hard, you guys. And I know it, people have said, well, I've tried this, I've tried that. And it's certainly, I recognize that. I'm not insensitive to people saying, well, oh, that's easy to say, but it can be done. It can be done. There was a question from Kaylee Carroll. Kaylee says, can you give a good way to explain to families when a fast decline happens? Maybe they were doing okay last week and now they had a fall or some event, or may nothing now. They are more confused, physically decline, not getting better with medical intervention. It's sometimes hard to wrap your head around decline related to dementia when it happens so quickly versus more progressive as we usually describe it. It's true, if it just comes upon us quickly, it's a shock, and the family feels like, they need answers. If it's coming on more slowly, they're accustomed to this decline.
And Gina,
Yeah,
I'd like to add to that, because oftentimes, you can have a delirium that's superimposed on a dementia. So the person can have an existing dementia, and then all of a sudden, maybe they develop an illness. It could be something like a urinary tract infection, could be, something like pneumonia, because older adults tend to have an atypical presentation, to illnesses per se. So they may have some underlying illness, and the presentation of it is so different because, they don't have the normal symptoms that we see, and we don't recognize it as health professionals or family members either. And so we always, advocate in this situation when something like that happens suddenly, abruptly, to always seek out a comprehensive, medical exam, because it could be, some type of illness that can be detected, treated, and then the person restored back to their prior, level of functioning. And so we know that great emergency room imposter, oftentimes when older adults show up, they're confused, disoriented. They may even become combative, strike out, and then, they get that urine and run other tests or so, and then they can identify, those underlying, medical, conditions, or if they notice in terms of the person's overall level of alertness, they tend to become, like more, like lethargic, and that happens all within a short period of time. They should always think in terms of, I need to get a medical evaluation. Then oftentimes, sometimes it can be due to maybe even consider coming up to the holidays. A lot of times when families, get together, Thanksgiving, Christmas, and there might be unfamiliar faces, so to speak, maybe more noises, things that are happening within the home, or maybe a family member, they're going to go decide to visit another family member in another city, another state. Maybe that person, so it could be relocation, trauma that's causing that, because they can't make sense, out of the environment. So we just have to always more or less to look at it from a more comprehensive perspective.
exactly. And you're right. Here we are. We're coming up on the holidays, right? So there will be a lot more activity. No matter where somebody is, they might be feeling that, that there's something revving up. There's activity. People may be coming into town to see them. There's just a lot more action going on, and we've got to be aware of that. And sometimes to them, it's new faces showing up, right? To them, this is a new person coming into their environment. And so that might create them to, might create a situation where they feel maybe threatened or uncomfortable, awkward, confused. So, and this is important for all the family members in the audience, if you're planning to get together with, somebody coming from out of town, maybe they haven't seen grandmother in a while and they want to see her, and that's wonderful. Be aware, what that, and we're not saying don't stop, to stop that. Certainly that's great, but be aware of that and be sensitive to, what's going on with grandmother in her brain and what stage she's at, that might cause some disruption for her. So, and when I say that to family members, I'm telling you, they are the experts. So I'm not saying this like I'm
Right.
teaching something new. I'm just reminding everybody, because you all who are at home with persons with dementia, you are the experts. And just to speak to that, I want to say that one of the comments that we got was from Diane. Diane Pitts was saying her advice to hospital staff is to follow the family or the caregiver lead. So that they, follow them, see what they know about it, so that will help you not escalate an issue for professionals that are in the audience, that, this is what Diane is asking and recommending. Good point. Thank you. I want to go back to protective services. Tamala, I have a question for you.
Okay.
Sometimes people are fearful of, maybe they're fearful of getting involved if it's a neighbor or something. I'm gonna come up with I have a scenario for you, but I'd like to ask you, how can you reassure family members that they're making the right decision by reaching out to you? Can you provide a reassurance to them about, in case they're hesitating about calling EPS, because maybe they're unsure of what's going to happen, once somebody's called? Can you kind of run through the steps to give them some reassurance and maybe some
Okay.
education on what happens?
Okay, a lot of times I see with family members, their ongoing dynamics in the family, and it's been going on a long time. And a lot of times they're hesitant about making a report because they don't want to be revealed. They don't want to cause any more dynamics with the client or other family members. So we reassure them that they're going to remain confidential. We're not going to disclose their name, contact information, anything of that nature. We also assure them that we're going to act in the best interest of the client's well-being at all times. And a lot of times that kind of, open them up to, okay, we're going to be it's going to be confidential, so we can make the report, and they're going to act in the best interest of my mom, my dad, or whomever they're making a report about.
So that is certainly reassuring, because
Yes, that's reassuring. We see that a lot because they're more worried about being exposed. And once, the family members find out that they made the report, it's like it tears up the family. Like, it's so much dynamic. And then the client just refuse services. It's just a whole lot comes with finding out that another family member or whomever or a neighbor made the report. So once we reassure them, you will not be, your information will not be disclosed. Everything that you report to us will not be repeated. It's strictly confidential. And then they open up more, and we get them to help us a lot with evidence and things of that nature. So, I find that that's very comforting to know that, okay, I can make this report, but they're not going to go and provide any information about what I said.
Good. And that, because they perceive it as being the person that got somebody in trouble, or them being the one that led to them that may be going into a hospital or a nursing facility. Now, I do hear this sometimes. The family member makes the call and then they don't hear back. What type of feedback after the investigation can they expect, or will there be none, or how will they know something is being investigated?
Now, due to confidentiality, we don't provide that information via phone because we never know who we're speaking to. The only feedback that we can give is we have an open case or closed case, or the case is unsubstantiated or substantiated. Again, we don't know who's on the other end of that phone. So we're not going to call and provide that type of information because it's strictly confidential.
Okay, so that, they're told that ahead of time.
Yes, they're told that at intake.
Good. Now, you guys, I have notes in the chat box in front of me, so I can't see everything. But Shannon, did you have your hand up about something?
Well, it's not earlier when we were talking about the holidays and different things, I think one of the key things is sometimes just recognizing what's in the best interest for that person. Like we want it to be a certain way. Like sometimes the holidays are going to be different than they were before. And just realizing that we were speaking about that earlier, just realizing what their needs may be. I think somebody wrote it in the chat. It may not be staying as long, or it may be that it looks different. Maybe you go visit that person if they live in a like an assisted living, or if they live in their home, maybe a smaller group goes and visits them. Maybe being open to doing things differently in light of some of the circumstances, I think can be really beneficial to the families too, for all involved, really.
Right. So sometimes we're trying to have the exact same Christmas that we had before, even though grandmother's not doing well. We want to do it so that everybody feels like there's the
Right.
traditions being kept, right?
Right.
And that we're still having this ritual. And it doesn't have to be, it can be adjusted, and still everybody gets the sense of tradition and togetherness, but maybe it doesn't need to be as long, or maybe we need to have a backup plan.
Meaningful can still be different, I think, is something important to recognize.
Right. Still be
For
me.
the holidays, but anything meaningful interactions, you can still have certain connections. They just may be different in a different way, like just being present with that person, or listening to music that they used to enjoy together and watching them enjoy that. But it's just being open to recognize. For us, it has, I speak for our family, being able to recognize that we may have to do things a little bit differently than we did before, but it can still be meaningful to us.
Yeah.
And to her.
Yeah. This is a challenge that many people are going through right now as they plan for the holidays. I had a scenario for you, Tamala.
Okay.
So here's the situation. My mother has dementia. She refuses to leave the house. She's appears to be losing weight. I don't think she's taking care of herself. She gets aggressive if I try to encourage her to do something. I don't want to escalate it. But I'm seeing now that she's starting to hoard. There are boxes and trash in her house, and I'm fearful, but she's not cooperative. She won't let me take her to the doctor. And she's getting more secretive. So I think that she's getting paranoid. And I'm worried that, actually that maybe some animals have gotten into the house. Tell me, I've called your agency. What would you do? What would you look at when you got there? And then I have a follow-up to that. So go ahead.
Okay, so there's two key terms I have to put into perspective with this scenario: refuses and capacity. Okay.
Good.
Now,
Good. Thank you. That's
okay.
That's what I want you to address, because people have a lot of problems with that. They say, I called them, they didn't do anything.
Right. We hear that a lot, and they think we're not doing anything. And that's the big problem. Because if that client has capacity and has not been deemed incompetent by a neurologist or psychiatrist, the client has the right to self-determination according to the law. So we can't go into the home violating the client's rights. We can't go into the home, telling the client how to live. We have to go in with a different approach. We can offer services, to make the home better, like cleaning services, home help, if that's what the client wants. But again, you have to look at the capacity and the right to self-determination. Now, if the client does not have capacity, just say we follow up with the neurologist and the neurologist states, hey, this client does not have capacity, requires 24-hour care. Okay, now that's a whole nother ballgame. If there's no family members involved, then we can get a protective order and we can place that client in the nursing home if there's no family members. But we normally like to let the family members address their loved ones, because they are going to act in the best interest for their family, because that's their family member. But if there's no family members, we're going to step in, we're going to get a protective order and place that client in a nursing home to get the adequate care, 24-hour care that he or she needs. But again, those clients who have capacity to say, hey, get off my property. And the doctor confirms it. I don't want any help. It's not very much we can do, even if we offer services and they are very, very adamant and consistent, with leave me alone. I'm not doing anything. It's just, we have to walk away from those cases. We hate it, but we have to walk away.
Yeah, I've heard the dilemma of, the APS and the EPS workers when that happens. Could you talk a bit more about capacity? How does somebody on the ground there judge capacity? Because what if the neurologists, they don't have access to a neurologist at that point?
Well,
They're there and they see the situation it looks like, yes, that person's hoarding, but maybe a little bit worse. Like maybe there's food in the sink that, they might not be like this person that we're talking about has lost weight and we're now worried about their health.
OPC, that's our next step. When we walk into the home and we see those conditions, we direct our specialists to go to the coroner's office because we need to know what's going on. Okay. And again, once they, go into the coroner's, we go to the coroner's, they do the pickup and everything and take them to the hospital, and the neurologist, psychiatrist, and whomever is involved with that particular client say, okay, this client has 24-hour care, decision-making capacity. We're going to have to discharge them back home. We'll follow up just to see if they would allow us to get the services that is appropriate for their needs. But a lot of times they are, they refuse. Like, it's just nothing we can do when they refuse.
So would you recommend at that point that the family member continue to monitor the situation? Let me ask you this. If they can give you more evidence that the person is starting to lose capacity, do you keep in touch with them for that? So they could say, okay, I understand that you've made that assessment, you've done this investigation. I will continue to be involved with this person. Is there a continued contact so that they might be able to say, it's looking bad. Let me tell you what happened today. And now I have more evidence that this person does not have capacity.
It will have to be a new case open because once we only have we have a time frame to monitor cases, and a time, if there's no evidence to support the case, then after a while we have to close it. Okay. But if they call it in a new report and there's some new changes, then we'll investigate the new changes and we'll go from there.
Okay, so, it can be revisited, certainly.
Yes. It just say we close that case, it's unsubstantiated, wasn't enough evidence. And then again, the doctor is the key here when it comes to clients who lack capacity, because we're not doctors. We can't make that call. We can't say a client lacks capacity. However, if the doctor says, the neurologist says, okay, this client has capacity, that's that. As far as that, we can follow up. We will follow up just to see if we can offer, services, and maybe we can wear the client down to, and sometimes we do. We'll just keep, talking to them, and telling them, hey, you shouldn't live like this. This is not good for your health. A lot of things goes on with that. And then sometimes we'll break them down. But a lot of times we have those that are set in their ways and they are adamant, and I'm talking about is like a brick wall. No. And, we have to respect that. Again, we hate to walk away from those cases, but, we have to respect what they want.
Yeah, you bring up a good point that sometimes it's that new person that comes into the situation, like one of your investigative staff members, maybe, that go in, and for some reason they develop that relationship, that bond. And that's something that many of us in the community are hoping grows everywhere, with police, with sheriff deputies, with your staff. We're looking for more and more people to be educated about this, because we recognize they might be that person that can develop that bond that can de-escalate the situation so it doesn't turn into a catastrophic event, or that you can convince them to get help, or to look at services. So everybody out there in the field has that's an important role they play, and
Yes.
that's why we want more education about this. I want to go back to about who would not be, who would not, be a good person to, that we should call about. Because sometimes people do maybe make a call to the coroner's office or your office, and that's not really the point of that office, or not something they can do. Dr. Clark, if I were going to ask you, is there a type of call that you get that really doesn't belong at your office, and only if this happened that it would have been prevented, or if something else would have happened, it could have been prevented, or if they had gone here, it could have been prevented? And where would those places be, or where would those services be that might have eliminated an unnecessary call or visit to the coroner's office?
Well, honestly, generally speaking, by the time they're calling me, it's because they need me.
Okay.
It really truly is. I mean, people are at, kind of at the end of the rope of the scenario where they're really in a position that is crisis. And so, every now and then, I suppose we get a call, and the individual is voluntary. They want to get help, right? And so that certainly is the coroner has no role in a voluntary scenario. And, we refer them to whatever community resources might be available depending on the circumstances in the case. A lot of these individuals, because they're older, typically have physicians, so I say start with your doctor, and or whoever your healthcare team is, and go from there. But far, 99+% of the people that call us need us appropriately, because of the scenario.
Well, that's good to know that people, that's happening, and thank God that you're there and your people are trained to deal with these situations. That's good to know. We have about 5 minutes left. Are there any other questions from the audience that, you got a panel here right now, got the coroner's office, and we have hospital representatives and EPS, and we have Dr. Spurlock. Do you have any other questions for any of the panelists? Am I missing any questions? I'm just going through the chat right now. I may have missed something. Ellen, do you see any questions that,
I don't see any more, Gina. I think you may have covered them all. Does anybody have any more questions? If anybody'd like to submit some in the chat, you're more than welcome to.
well, I want to say, I think this has been a very fruitful, get together dialogue from everybody. I appreciate the time. I know everybody on this panel is very busy. And I know the audience is very busy, and for you to take out an hour and a half of your time to learn more about processes, learn more about services, and learn more about dementia speaks well to what's going to be happening in our community. I want to thank everybody that came. And Ellen, if you want to say if somebody needs further information or how to reach you, if they need any follow-up information.
Absolutely. And thank you, Gina. And thank you to all of the panelists. This has been, just like Gina said, such a fruitful conversation. I know there's been a lot of wonderful information shared. So thank you to each and every one of you. And thanks to everyone who joined as well. Just to follow up from a few of my announcements at the beginning, in case you came in a little late, what I'll do is after this presentation, I'll be sending out a survey. If anybody who needs a CEU or just everybody that participated could complete that survey and get that into me, I would really appreciate that. If you had any technical issues or anything during the presentation that caused you to have to leave the Zoom room or anything like that, feel free to follow up with me after. I'll put my direct line, and of course you'll have my email when I reach out to you guys afterwards. So if there's anything we missed or anything else I can help you with, just be sure to let me know. And again, thank y'all so much. This is a wonderful presentation.
Thanks very much.
Wanda and Ellen, if we got a few minutes to talk.
Yeah, I'm hanging on. Looks like we still have a few people
Good.
in the meeting room.
Bye, everybody.
That was great.
Yeah, it was great information. Great information.
So diverse. That was just rich information. That was rich,
yeah.
really rich. You know, to hear more from the coroner's office and, you know, protective services, you know, like all in one. you know,
People have,
setting.
yeah, people don't often, they don't really always have a good idea of what's really happening there. I'm looking
Mhm.
at myself, my face looks of like I look like in one of these alien movies. But I couldn't see myself because I was looking at my notes.
Let me see. I still have a couple people hanging on. And thank you, Gina. You always do such a wonderful job of keeping it so organized and giving everybody good time and everything like that. You do such a great job.
Keep the conversation moving, and it was so
Mhm.
connected. That was just great.
Yeah. It
Just
always
like-
feels so natural.
I do start to get a little nervous, like what we're doing with the time, because I know that for, the CEUs, it's important to stay to exactly the time. So 5 minutes is fine.
Yeah. I think we were like right at 128 when we finished.
Oh, yeah, we were fine.
Yeah. Yeah. Let's see.
We got a couple people, I don't know.
Let's see. I can move some people. Okay. It's really just us. It's Christy and Barbara are also logged in, but I know they're both doing other things too. So
Just a quick question. So Ellen, you asked me if you said you need a speaker about psychosis. I mean, and I thought I'm really not an expert on that.
Mhm.
And I know it's a lot to do an hour on that. What is the topic exactly? And I was thinking, it might be something that Wanda, I'm sure, could do an hour, but if not, we could do pieces of it. Tell us exactly what it is that you need.
Yes. So one of the big topics that we got requested, and I know Dr. Spurlock, you've done some presentations for us on, you've done the Managing Challenging Behaviors Lunch and Learn. And so it's almost like a follow-up to that one. So this was a big one that we got requested. It was calming a person with hallucinations, paranoia, and accusations. Like after the incident, how to respond, what to say, and maybe even like some self-care tips for a person that is so worked up and so agitated, so irritated. And so that was something that was put a lot in the comments post lunch and learns from the last year. And so what do y'all think about that? Like, do y'all think that's something that?
Well, we do the presentation for GWEP that
Mhm.
has a lot of good information that could speak to that. We do an education thing, but and certainly it would include some things like external, Wanda, how we talk about the external environment, what can be adapted or rearranged in this situation, or how to handle somebody that maybe is having a delusion. And I think we could talk about some, I know that some of the TIPA Snow stuff, we learned about how to redirect and even talk about validation therapy, file. Is that something that what do you think, Wanda?
I think in just even trying to, understand, again, going back to person-centered, because sometimes in all my visits to nursing homes, they will want to call the physician to get the resident put on an antipsychotic because they say the resident is hallucinating. And then when we ask more information about it, well, they're saying that they're hearing little, babies crying, like in the next room. And, sometimes it's the case that they may have been a school teacher, maybe worked in daycare. And so, now they're hearing baby. So it's not something that's really presenting, an immediate, like harm, a threat, a danger. And so we have to, educate is that all type, and sometimes it's just really based on their level of what confusion and disorientation, and based on where they are in that whole trajectory of the disease process. So that's not something that we need to try to treat, necessarily medications, but to try to help them understand, what those delusions and what they're referring to as hallucinations and all, what it may be grounded in.
Yeah.
Just in their life experiences that they're trying to make meaning of at this point. And so they're going back in time. They're like locked in time per se.
We would talk about that, but also like after maybe it was a catastrophic event and maybe there are some sore feelings, or maybe people are still feeling awkward, how we could help them work through that, through the, de-escalation. And this is how you and I are interacting now. And we're still together. I know that we had this little ugly event that happened, but I'm not pouting and I'm not, talking angry to you. We are still, we're still together, and I'm gently talking with you, and I'm reestablishing that relationship with you.
Right. And we're not taking it personal, and we're not carrying over the aspects of one day to the next day.
Exactly. That's what I was going to say, not to get too hung up on one incident, and not, I think that would be really, really important for caregivers as well, because sometimes they just get so upset over those, those
Ugly for them
incidents, and
too,
it makes
yeah.
everything in the future more difficult. It's only a natural thing, I think, to have your feelings hurt when someone's screaming at you or things like that. But even some self-care tips for caregivers in that respect as well.
So do you think we could do something, Wanda, and break it up between me and you and do an hour? I mean, I know you could do 2 hours of that, but do you think that this would be, and when would you need this, Ellen?
Let's see, I can actually pull up the dates that we have available right now if y'all want, and I can tell them to y'all. We have March, and they're all 2022 dates. March 9th, June 8th, or September the 14th.
Honestly, June 8th, I'm out of town, and then I'm gearing up to do a TIPA snow presentation in mid-March that that's still kind of new to me. I mean, it takes me a lot of focus to do that.
I was going to say in March, because then we'll have our on-site accreditation visit again in March of 2022 for the BSN and the master's programs.
Are you okay with September at this point,
I think
Wanda?
September would be a better.
Okay.
Oh, great. Okay. If you guys want to come up with a little title too, that we can name it, but I will secure y'all for the September 14th date.
Okay, and maybe even, do a little a scenario, even saying, okay, I'm the mother, I'm yelling at you, and then, like do a little, I don't know, role of how this would look. Well, this is what we're talking about. This is how it would look.
I love that. Yeah.
Okay. Wanda, let's email each other and look at some titles, and we'll send it to
Yeah, we'll have a little time to plan, won't we?
Yeah, y'all have a good bit of time.
Okay. All right. But when do you need the title? Do you need it on a
The title just by the end of this month, if possible, so I can get the schedule published in December.
Okay. All right. So we'll throw out some things. Me and Wanda.
Okay. Yay,
right.
that's going to be awesome. Thank y'all so much.
All right. Bye, you guys. Thank you.
Thank y'all both for
Thank you,
today.
Dana.
I'll talk with y'all soon.
Bye-bye.
Bye.